Okay, so let's begin with some a warm welcome to everybody. Thank you all for tuning in to this webinar, our first of a series. Before I begin, I just want to quickly do an introduction of the AMSNY team. Joe.
Hello.
There's Joe Wiederhorn. Not sure if everybody has met her or has not. She's AMSNY's president and CEO. And we've also...
Thank you all for joining. Really appreciate it. Go ahead.
And we also have from staff here with us, Jenny Tassler. She's our Director of Policy and Programming.
Hello, good to see you all.
Great. And for those that don't know me, I'm Britil Badao. I'm the Director of Diversity. And Jenny and I have teamed up, of course, with Joe's lead to kick off this, we're hoping what will be an incredible series, a webinar series. And this Diversity in Medicine webinar series has a couple of goals. One is to dispense information, provide information to all of you. And not just information, but good advice. And along with that, hopefully some opportunities and the chance to network. And because it's for our post-bac, current post-bac students, as well as post-bac alumni. So some of you are medical students who are post-bac alums. We sent this out. We will make it available to our residents, practicing physicians. So anyone who has been through our post-bac programs, one of our post-bac programs, dating back into the early 90s, can participate. So again, an opportunity to really network and increase your colleague connections. So how are we doing this? We are hoping to create this much more personal setting here by inviting the right individuals. You'll meet today's guest speaker in a second. And the goal is to invite a very diverse array of speakers. So by diverse, we mean coming from different specialties in medicine. We also mean having different roles, right? So we actually, on the call today, we have with us a Dean of Diversity. Dr. Camille Clare has joined us as well. She's the Dean of Diversity and Inclusion at New York Medical College. But having speakers such as physicians, Deans of Diversity, maybe individuals that are involved in academic medicine, individuals involved in community work. So really giving you a broad spectrum of different activities. Also by diversity, we mean cultural backgrounds. So we're hoping to bring on individuals from not so traditional paths who have taken these not so traditional paths to get into medicine. And these are folks that you can hopefully better relate to and understand. So with that being said, other than Joe, Jenny, and myself doing some work on our end to recruit individuals to speak, we are putting out a call for nominations for speakers, our future speakers, to you all, because you all know what's up. You, I'm sure, have had amazing individuals that you have met who are practicing physicians, who you think would be a really good person to invite and speak to your colleagues. So again, who would be a good speaker? Someone, doesn't have to be, but if possible, someone from an underrepresented background, a person of color. If you know an AMSNY post-bac alumnus or alumna who's a practicing physician, that's another plus. If you know someone who's practicing in New York State, since we are a New York State-centered organization, these are just pluses, they're not requirements. But please send us an email, send me an email, send Jenny an email, and we'll take a look at your nominations and keep this moving right along. We hope to build it up. All right, so we're still letting folks in. This is great. For tonight's format, here we go. For tonight's format, I will be the moderator of the discussion, and Dr. Okafor, of course, is our guest of honor. So I will be asking questions to help facilitate the conversation. And as we're talking throughout the hour, please ask your questions. And I think the best way probably to do this is use the chat to write your question down. And as I see questions popping up throughout the discussion, I'll call on you and you can ask your question to Dr. Okafor. All right, sounds good? Okay, fantastic. Thank you, Jenny. There we go. See, it's working. Teamwork. Okay. Yes, so use the chat to ask real-time questions. I already covered that. Fantastic. So with that being said, I actually wanted to see if we have quite a number of folks on, and I was debating if we should do a quick introduction of students, but because there's a good number of you here, we're probably going to skip that part, and you'll have the opportunity to introduce yourself when you ask a question. Okay, Dr. Okafor, let's turn this over to you. So thank you again for joining us tonight as our guest speaker. It is a pleasure to have you back with us.
Same here. Yeah, same here.
Great. So I'm going to leave the introduction to you. So if you can please give us a brief introduction of yourself and we'll start from there.
I mean, do you want me to just reiterate that single paragraph I sent to you, or what? Kind of just from there?
Yeah, that would be great.
And I guess expound a little more than that?
Perfect.
Okay, I'll start. So basically, thanks again, AMSNY. They've done so much for me. So anything I can do, I'll give it back. But essentially what I am, I'm a board certified psychiatrist, and I work at a federal prison in New York. I can't tell you which one, but it's pretty known. And on the weekends, I also work at a private inpatient psychiatric hospital. I finished residency in 2013. I went to what is called Rowan University School of Osteopathic Medicine, but it used to be called UMDNJ, which was the University of Medicine of Density of New Jersey. But politics and, you know, that kind of stuff made them all separate and break apart in 2013. The same year, actually, I was graduating. So now it's called the Rowan University School of Osteopathic Medicine. So I'm a DO. Yeah, I mean, I became board certified in 2016. I work at a federal prison where I see underserved community all the time. In fact, the scholarship, I won a scholarship years ago in medical school called the National Health Service Corps Scholarship that required me to do 2 years of service for 2 years of getting the 2 years of receiving the scholarship, which actually is kind of, you look back at these things like it's kind of a blessing, because I only had to do 2 years and I would have completed my obligation. But now it's 7 years into my career with the Federal Bureau of Prisons, and I genuinely love my job. I love that I get to help somebody who's coming in, whether it's their first, second, third charge, whether they have previous mental health history or mental health symptoms that develop in prison, including the typical anxiety, depression, and irritability. And I get to see them daily, Monday through Friday, sometimes on the weekends too, and kind of help them, whether it's through therapy, whether it's through medications, help them kind of get through their cases, because where I work at is just a jail. And that's a term that means essentially people who are there are currently on trial or pending trial. When they are done, they usually go to prisons, which is where you hear, you know, like the ADX, ADX or those big prisons where people serve the remaining of their time. So my job is kind of to help people as best as I could, and my colleagues maintain their mental health needs while they're in the jail, so they can go through their trials and go through their trials to move on to the next step, and hopefully serve their time and once again become productive members of society. So that's what I've been doing for the last 7 years. That's my Monday through Friday job. On the weekends, just for like more experience and just more knowledge, I continue to work at a private inpatient psychiatric hospital where I see kids, I say from not womb to tomb like family medicine doctors. I would say I see kids all the way from young as probably 7 or 8 to geri patients, all the way up to 85, 86. I think I have a patient right now who's 86. And I see them, I take care of them. I'm the weekend doctor from Saturday through Sunday evening. Saturday morning to Sunday evening, and I just continue care that's already started during the weekdays, and I really enjoy it because it really keeps my knowledge up of adolescent medicine, mental health medicine, psychiatric medicine, all the way to geriatric psychiatric mental health needs. Because at the prison, I guess the typical age range is typically 19 to maybe 50. So I don't see the uppers and the real higher end of the age limit and the lower end till I go to my job on the weekend. So yeah, that's what I do. I do that Monday through Sunday. I don't work every day. I take every other weekend off. So don't think I'm overburning myself, but I truly do enjoy what I do. And I'm so thankful that people let me share in their weakness so we can both together continue doing better for each other. So I'm always blessed that somebody has trusted me with their care. I'm always thankful for that.
Thank you. Thank you for that introduction. Wow. Before I continue, I wanted to let everyone know that as a request from many students who could not attend this webinar, they asked if we could record it. So I wanted to let everyone know that it is being recorded, and let me know if there's an issue, hopefully not, because we do want to make this available to everyone. And I apologize that I did not mention that in advance. It will only go to AMS and Y students. All right, so Dr. Okafor, let's back up just a little bit. Can you share with us, how did you know that medicine was your calling?
I mean, so that's like a great question. Essentially, I'm the oldest of four. We're all in medicine in different ways. I didn't want to become a physician until in my college. Like, I thought I was going to be a computer scientist. I thought I was going to work in coding. I thought I was going to be one of those, because this is back in, like, I'm revealing my age here. I'm 37. This was back in early 2000, 99, when like you went to college, you're thinking, oh, I'm going to be one of those .com millionaires. I'm like, I want to do that. I think this is going to be an amazing opportunity being a coder, just being in the computer science field. My first year, I went to City College of New York for my first year. And then the last year I went to Rutgers University. I met these kids who are going to this special 7-year program. It used to be called the Sophie Davis School of Medicine. Now I think it's transitioned to now it's no longer a 7-year program. It's just a straight year, 4-year medical school. But this is when the program was still going on. So I took a lot of introductory courses with these some of them are my longtime friends now. And they were like, oh, Shooty, that's my nickname, guys. They're like, oh, Shooty, why don't you try and see if you could do this medicine thing? Because I wasn't in love with computer science and all this other stuff. I just thought I needed to do it to make money. Like, I come from a Nigerian background and my parents are the first generation here. So I wanted to make sure that later in life I could support my family, my future wife, my parents, just to have something to support them. And I wasn't stuck on being a .com millionaire. I just thought it was something to do. I thought it was something that's going to provide for my family financially. So when they mentioned that, they said, hey, why don't you try medicine? And it's the short end of the story is I took more medical courses. Pre-med courses, and I loved it. I thought it was very interesting. I loved human body, especially physiology. And then later on, like I guess more mental health related kind of courses like psychology, that kind of stuff. And that's and I went straight forward, and that's what I did.
Fantastic. So to build on that, and actually I think Robert just asked this question.
Great. Okay. Hey, Robert, how are you, buddy? So why psychiatry? Okay, so this is how things just happen, because they just happen in life. I told you guys I won something called the National Health Service Corps Scholarship, which, by the way, in the future, you guys should look at that, and also the National Health Service Loan Repayment Program. So I've done both of those. I did those for the first 4 years post-residency. But let me go back. So I thought coming into medical school, I was like, oh, I'm going to be an internist. I'm going to be a black cardiologist. I was excited. I'm going to be a black cardiologist. I'm going to be medicine. I'm going to be a black cardiologist. Okay. The third year, which is the first typical year of your clerkship, I did internal medicine rotation. And honestly, I did not like it. I said, oh my God, this is so redundant. I have to see it. I thought I was going to see 30, 40 patients easily, the same physical, I'm doing the cross, I'm sorry. the same, heart exam, auscultation, stomach, blah, blah, blah. I was like, this is not for me. So I went through all the motions of the year, clerkship. My last rotation ended up being psychiatry. And at that time, I didn't know psychiatry would even fulfill, because with the scholarship, there was a caveat that you had to do you had to go into 5 residencies, one of the 5, which is the primary care fields, which obviously is are the very underserved specialties in medicine: internal medicine, family med, OB, peds, and psych. I never looked at psych because I didn't even think I was going to do psych. But then my last rotation ended up being psych, and I truly loved it. I really liked helping people. I really liked that people share things with you. Like, we're the masters of the history. I really like delving into people, of course, with people's permission and their respect. I really liked it, and I got into residencies, and here I am now. I'm a psychiatrist for 11 years now. So yeah. So that's the story. That's why psychiatry, because it just happened to be one of those things that I just really fell into. And yeah, I was very lucky to get into the field. Very lucky.
Thank you. Robert, do you want to introduce yourself? Let everybody know your name, where you're from, and which school you're at.
Hi everyone, my name is Robert. I'm originally from the Bronx, but I live upstate now in Coquig. I did the post-bac program at Stony Brook. Just started my first year this week, so going strong so far.
Congratulations, man. I'm from the Bronx too, man. I'm from, I grew up around Gun Hill Road.
Oh, I have a bunch of cousins over Gun Hill Road. Nice.
Yeah. Dope, man.
Cool.
Congrats again.
Thank you.
Thank you for the question.
Excellent question. You led us right to the next one. So, Dr. Okafor, as you told us, you work in a federal prison.
Yeah.
And this is a unique setting for practicing medicine. Can you tell us a little bit more about how this opportunity came about for you and why you decided on this particular setting?
I feel like this whole thing is going to be just amazing, great questions. Yes. And tell me if I'm talking too much about myself. Like, I don't like to talk. I only did it because I think it's important to share your story. But if I'm talking too much about myself, please let me know. So essentially, okay, this is how it goes. With the National Health Service Corps scholarship, you apply to residency, but after you finish your residency, you have to fulfill anywhere from 2 to 4 years. I got the scholarship my last 2 years, so I owe 2 years service back. During the end of your last year, they work with you to find an underserved population or community, whether it's rural, whether it's the prison, etc. I was looking for jobs. I thought I was gonna move to I've lived in New York, New Jersey my whole life. Grew up as Gun Hill, as I told my man Robert. I grew up in New York, so I was like, I gotta get out of here. I wanna go to Texas. I wanna go somewhere else. So I was looking for community health centers or federal qualified health centers, same essential thing, to fulfill my 2-year service. And then this opportunity came about where somebody was like, oh, why don't you apply to be a psychiatrist at the prison? Okay, for a guy who's never been anywhere near prison, I was like, no, I'm not doing that kind of stuff. You watch too much shows, you watch these inaccurate portrayals of prisons and jails. And I was like, I'm not doing it. But I thought this could be an opportunity just to keep my options open. I went to their interview because prisons are considered underserved. Yeah, more underserved. So I went to the prison. I really liked the tour. I got to meet the inmates. Like, the inmates are not locked in all day. The inmates, they are around just like everybody else, walking throughout the whole institution, doing jobs, walking in their unit. They're not locked up unless, we'll talk about that later, unless you're on solitary. But even that, you're out for like a few hours a day or whatever. So did their interview, did the walk around, really, really loved it. I thought it was amazing. The patients I call all my inmates patients because to me, inmates are so informal. So I say everybody's a patient to me. Even when I write my notes in EMR, I still say patients because inmates to me it just doesn't sound like I'm giving them the same humanistic respect that I feel like they deserve. So I say patients for everybody. So I said patients, they were cool. I mean, I think they were, they were not as, like I said, as portrayed out like in the like they do in social media or TV. And once they came back with me with the offer, they said, hey, do you want the job? I said, yes. I was going to live in New York for a few more years, and that for 2 more years. And then I said, I could move away and do something different, but that never happened. I've been there for 7 years, and I'm hoping to stay for 20 years for my full 20-year career, if not longer. 20-year, because it's a federal, so I'm thinking pension-wise, but longer if they let me.
That's dedication. That's fantastic. I just, before continuing, want to let folks know, I know there's some new individuals that joined. As we're having this discussion, and this is a conversation, not a presentation, so we are inviting you to all, as you come up with questions that you want to ask Dr. Okafor, please type them in the chat, and we'll call on you, and you can engage. This is meant to be engaging. So type them in. All right, so, your patients are, I'm sorry?
I'm going to just put on more light. I'm sorry, I'm in my apartment, so I need to put on more light.
You're on vacation.
It got dark real quick. That's why I put on the light.
You're on vacation. You can have those cool virtual backgrounds or whatever backgrounds. You deserve it.
Oh, thank you.
All right. So yes, your patients are individuals in a prison. One of the questions I had was, what is it like serving patients in this setting? What are the challenges? Because I'm sure there are some challenges, unique challenges, as well as benefits.
The one challenge is that I'm still annoyed to this day is that, and this is probably why I still work on the weekends, because the medication formula, typically of the federal government, is not the most up-to-date medication formula. And that's very important to give patients the most up-to-date, new, more effective, less side effect tolerant, and most effective tolerant medication. It's not really up-to-date. Typically, like I said, it takes years and years before we get these medications that cost a lot of money until they become from brand name to generic. That takes a while. So it's up to me to kind of keep up the knowledge of what's going out, in community medicine with what's going on in the prison, what I can utilize based on the formulary. And the formulary, guys, is just the medications that you're allowed to prescribe and give, because in the prison, I don't have to worry about, which is a positive, I don't have to worry about pre-authorization and all this stuff that I know private clinics, community health centers have to worry about. But I also don't have the most up-to-date medications that I would like to use. So me working on the weekend helps me understand what's going on in the community medicine and also community techniques, because as the only psychiatrist in the prison of 800 inmates, 800 patients, I have to keep up the knowledge and make sure that I'm up to date in my knowledge, evidence-based medication, evidence-based knowledge. So that's probably why I should keep up with the second job, because it's important that I'm bringing the most up-to-date knowledge and care to these patients are in jail, not the easiest place to be.
Great. All right. So Robert it's as if you're reading my list of questions here, Robert. Same wavelength. So Robert asks, what do you think are some misconceptions about working or practicing in a prison? And along the same lines, maybe you just expand a little bit. What are the barriers that you face?
Oh no, I think the misconception, like I said, the misconception is that inmates are wild. They don't have no control of their behavior. Not true. Inmates are I see inmates. Like I said, they come from their unit down to see me. They're not in chains. They're nothing. Most of them have very good control of their behavior. I see inmates in my office with no chaperone, no anybody. They come and see you. They're very well controlled. Very well controlled. Do I have the inmates that once in a while, the ones that are once in a while, out of 7 years I've been there, do I have the ones that you're afraid that they're going to spaz out? Yes, of course, right? But you call a correctional officer to accompany you. But 99% of my patients I can see by themselves. They're very, and where the medical team in any jail or any prison, I think is very lucky, because patients, they look at us as people who want to help them. So they're very polite. They're very thankful that you're there helping them. I gather, because a lot of my colleagues are good people, a lot of my correctional officers, colleagues, I gather that because they have to show them discipline, this is where they might act out, because, you know, a 25-year-old correctional officer talking to a 40-year-old man, I could see the dynamic being, who are you? Who can you tell me what to do? They come to us, whether it's medical or mental, to see me, obviously. They know that I'm there to help them, so they're in their best behavior. I think that the question would be, if you would have to ask, would be to another correctional officer, what's the daily dynamic? Because my daily dynamic is pretty positive. Do I have like an inmate / patient, you know, sometimes med seeking, trying to get their way over me, trying to get one over me? Oh, absolutely. But I think that's the minority, not the majority. They're really thankful of their help that we're providing, because in my opinion, care is care no matter what. It's in the Constitution that inmates get fair and equal care, but in their eyes, they say they're lucky that they get the care that they get, and I'm there to serve it and bring it to them as best as I can. That's why I'm so driven to make sure I always have the up-to-date knowledge, and that's why I'm always reading, doing my CMEs, because if I'm not doing that stuff, I'm not giving them the most up-to-date care that they deserve.
You are exemplifying, I think, whether you're a physician or a physician scientist or a scientist, you know, to be able to serve your patients in the best way possible,
Yes,
to
ma'am.
keep yourself up to date. So I respect that. Thank you. So let's have Anthea introduce herself and ask her question to Dr. Okafor.
Hi, everyone. My name is Anthea Gomez. I'm a second-year medical student at Downstate, and I completed the post-bac in Buffalo last year. So yeah, I mean, my question was mostly like what does a typical day practicing in a prison look like on a day-to-day? Like, is it like assessments? Do you do psychotherapy? Like, what sort of care are you providing to the
Wonderful
patient?
question. Wonderful question. Pleasure to meet you. And how do you say your name?
Anthea.
Anthea. Beautiful. So essentially, I start my day every day at 7:30, right? 7:30, we all start out, the medical team starts their day at 7:30. From 7:30 to 8:15, 8:30-ish, we have, what's the term that they use? I say round table, but it's a technical term that they use, that when you all sit down and you talk about all the patients that come in, whether they need mental health, mental, medical, or both. We sit down, we talk about every patient. Typically, we get about 10 new inmates / patients a day. So we talk about who we need to see right away based on just policy. And then we talk about our patient, and then we take our load of patients that, for me specifically, I see like probably 10 to 15 patients a day, probably 2 or 3 new, just based on my everyday schedule. Not even if they came the other night, based on urgency, right? So I see them anywhere from, I start seeing about 8:30, I would start seeing my patients. I go till 12 o'clock. I see my patients till 12, see as many as I can. I try to get at least 7 or 8 done before lunch. Lunch is quick. Lunch is like 30 minutes, and then I get right back to it. Everybody needs time to sit down on their couch and just take it in, right? Breathe it a little bit. So then at 12:30, I start again, 12:30, and then from 12:30 to 4:30-ish, 4:15, I would say, I see patients the rest of the day. As far as the psychotherapy part of it, I have a psychology team, so they perform most of that. But when I see patients as follow-ups, not the new evaluations, but as follow-ups, I think I'm providing therapy within our med sessions. Our med sessions typically last from 15 to 30 minutes. So I think I provide it, but very informally. We have a psychology department that provides all that. I think we're about 6 to 7 psychologists are in my prison, and they provide most of that therapy. Me, I do it very informally. My goal is to make sure that they are on the right meds, right dosages, right lab work, and that the meds are not causing any intolerance. Because the first thing psych patients or tend to do that when they say that, or, you know, the inmates say this medicine is not working, is because they stopped it early because of side effects, etc. It's my job to monitor them. And I see most of my inmates about the first time evaluation. I see them in about a month. After the second or third time, I start seeing them once every 2 to 3 months. And I just want to make sure I follow up on them on what the meds are doing, because I always tell all my inmates that the medications I'm prescribing you are not Jolly Ranchers. They all have side effects, can have side effects. So it's my job and my blessing to follow up and make sure that they're not causing you any reason to stop it, because or else if you stop it, like I said, you're not going to have the full benefit of the medication that, you know, that they have. And also I look into whether or not the therapy they're having with the psychologist is working. So it's in 30 minutes, 15, 30 minutes, it's a full session. And that's why I'm also very happy I work in a prison. There's no rush for me to see my patients. I don't have the rush that a private sector has to see. I mean, some of my friends see 20, 25 patients a day, 15 minutes top, maybe 45 for a new eval. I don't have those time constraints. I'm very thankful that I can take my time and see my patients and really get to what's bothering them or what's not bothering them. If they're doing well, they're like, hey, Dr. O, everything is good. I'm like, okay, everything is good. Get out of here. They laugh and we joke around. But if it's something more serious, we take the time and we just, you know, there's no rush. And that's one thing I think about the prison jail system. Typically, there's no rush. I take my time with my patients.
That's probably a golden opportunity, because oftentimes we hear physicians saying they just don't have enough time to spend with their patients.
Absolutely. The private sector, I have friends who are physicians in internal medicine, psych, everything. It's just, it's a rush, but that's one of the other benefits of jail. There's no rush. Like I take my time and see my patients.
So Dean Clare at New York Medical College was mentioned. Is it the multidisciplinary rounds? Is that what you were calling your round table?
Oh yeah, so no, that's the rounds. Rounds is in the hospital. You go around from room to room, but it's something like that. Yeah, it's something like that. I haven't formally had to do it in such a long time. I just call it the round table, what we have every morning for an hour, 45 minutes to an hour.
Okay, all right. So before we jump to our next question, for those of you that have video on, by a raise of hand, how many of you are actually interested in or already in psychiatry? All right. Alemante, we've got a couple hands in, 3.5. If other folks are thinking, so you've got some students that are interested. That's good.
That's cool. I can tell you everything about it. So
appreciate it. So before we get to the next student question, I want to throw in this, and maybe it will help kind of give a nice comparison as people are thinking of their questions. So, you know, you talked to us a little bit about your work in the federal prison, and I wanted to see if we could compare this with your work at the private inpatient psychiatric hospital.
My weekend job, correct, my weekend job. Yeah.
So if maybe you could tell us a little bit about your work there, and same thing, what are the benefits, what are the challenges, so we can have this nice comparison.
Great segue. I guess, I mean, the weekend job is more of, the weekend job, it's like I say, a private psych inpatient it's a 117 bed inpatient hospital. My job is on Saturday, Saturday to Sunday. So it's 117 beds, but obviously we don't always have 117 patients. Typically our census is 100 people. So me and another clinician, whether it be a nurse practitioner, another physician, or another PA, because they can get this certification in psych, they can get the certification in seeing psych patients. We come together, we split the house, usually 50-50 patients that I have to see. So I see 50 patients, new ones and old ones that may come in. Probably new ones, probably 3 or 4, but the old ones are probably 45. So I do that from 7 to 1. It usually takes me about 6 hours to see all those patients, right? And what we do is that we split the house, whether it's the Jerry unit, the adolescent unit, the adult 2 units, which are like more severe mental illness, people who are schizophrenic, people who are bipolar. Jerry has all of that. And then we have a dual unit, which is the combination of mental health and substance use disorder. Then we have the adolescents. The adolescents range from as low The youngest I think this weekend was, I believe, 8 or 7, but the oldest you can be is 18. After 18, you have to go to one of the other adult-centric units, whether it's Jerry, whether it's adult. I see them from 7 to 1. I see about 50-something patients. And then I stay, so that day, so one person, either me or the other mental health clinician, you either stay in a house or you live. Me, I usually work the whole Saturdays because I'm only going to be there once every other week. I work from 1 to 12. I'm just an in-house doctor. I take care of additional medical related stuff. I see any new inpatient, any new incoming people who come in for psych, but I also take care of their medical needs, which is another thing I like about that job. It actually keeps my medical type knowledge pretty much intact. Not as much as if I did it Monday through Friday and I was an internist or a PEDS, but that keeps my medical knowledge, I think, more knowledgeable. And I do that. And then the next day I do the same thing till the evening time. And then I leave early in the evening on Sunday, probably around 5, because by 5, another physician will come in and take my place. So what I like about the private sector, like I said, it really keeps my community medicine knowledge on point, which to me translates me to being an even better clinician to my inmates from Monday through Friday, my Monday through Friday job. So that's probably the benefit of working that second job more than anything. And when you're only the psychiatrist, there's only one of me there in the federal prison, you can get very full of I don't want to say full of yourself. You get very egotistical about how you treat patients, right? So I like seeing how my other clinicians are treating patients just by reading their notes, seeing what they're doing. So I compare what I've done, and, it kind of helps me figure out, just keep up my knowledge. It just helps build on it more than anything.
I mean, I appreciate that practice. We're always learning. We're always trying to grow in our roles, no matter
Absolutely.
what level of experience we have. So,
absolutely.
Yeah. So, Joe, I know Dr. Okafor talked a little bit about his patients. Did he answer your question? I know you asked a question about patients.
Right. So I'm just curious as to how you get your patients. Do they automatically have to see you once they get into the prison? Do they say, I want to go talk to somebody?
Oh.
How's is there clearly a referral process?
Oh, no,
how does that work?
Absolutely agree. So during that morning rounds, we have morning rounds at round table. We see, we have a morning round table that we get a census. The census is usually, like I say, 10 new inmates / patients. From their intake, so essentially my job has medical coverage from 6 a.m. to 10 p.m. Usually till 10 p.m. we accept inmates, and somebody in the medical staff will do their intake. And during the intake, the inmates let us know their history, or we already have records of their history because we have a national EMR system. So we know whether or not they have mental health needs. We already know they have medical needs. So come the next day, 7:30, 8:30 roundtable, we've already spotted people who need to be followed up because they're on psych meds, or they've requested psych to be seen. Sometimes if it's just something that's basic and, how can I say, just incoming anxiety from being in prison, they'll just see psychology. But if somebody comes with meds like Xanax or anything like that that's within my range, I will see that patient and see why they're on it, whether or not they need to continue, which if it's anything addictive, I have to change it into something that's on the formulary, while safely tapering them from being on Xanax and Klonopin, because those are medications, unfortunately, you just can't stop. You have to medically taper them and switch and substitute it. So I do all that. I have to see them, and then we'll work on the plan together. Treatment planning with inmate / patient is very important. So I try to see those people immediately, the people who need to be seen quicker based on them having such a problem. Then throughout the week, I get referrals by the psychology department. They might say something like, oh, we've worked with this patient for the last month. His anxiety or his sadness is still not improving. They notice a change. Other officers are saying they know the change. Then they refer to me, like they send an email to me, or we actually have a system where they can send it to me. But throughout the bureau, but it'll come to me because I'm the only psychiatrist at the prison that I'm at. And I eventually make time to see them, whether that week or the next week. But I try to see patients when I get a referral within 5 days of getting a referral, because my schedule allows me to see them that fast.
Okay.
Did I answer your question, Ms. Joe?
Yes, you did. Thank you.
Okay.
Excellent. All right. These questions are rolling in. Thank you, everyone. Danya, and I don't know if I pronounced your name correctly. I just saw her. There she is. Did I say it? Danya? Okay, wonderful. You asked an excellent question. If you can please introduce yourself and you can ask your question.
Yeah, I'm Dania Contreras, and I'm from the Bronx, and I'm gonna start my post-bac summer, well, not summer, but fall semester now. So, not a student yet, but pre-med.
Welcome.
Thank you. My question was just, how do politics and public policy affect your job at the prison?
I can honestly say, for me, it doesn't. Like, I'm literally, because I'm telling this, being in the federal prison shields me from a lot of that stuff. It doesn't at all. Like, I'm just the clinician. I don't have to deal with that stuff at all in any way. If I was in the private sector, I'm sure it would, for sure, whether it's payroll, whether it's, just medication formulary, they can afford it or not. But because I work at a federal prison, I'm kind of shielded from that, right? Like, I don't deal with the private sector problems. So directly it doesn't affect me, but I know it's affect my colleagues in the private sector. I know it does. Like with the whole COVID thing, like it didn't affect my salary. It didn't affect me getting paid. That's all luck, because we get a budget already. They already have their budget set aside. Unfortunately, when they had this furlough, sometime I believe last year, I didn't get paid for 6 weeks. That's when they didn't have the budget at the time. So when we had a new budget, finally, that affects. So that's so it has affected me when it comes to something like a furlough. A furlough is a time when a federal government employees, they have to go to work, because we're considered essential, and you don't get paid. I didn't get paid for 6 weeks, I believe. Last year, before we had our budget, before the federal government set aside a budget from my department, which is the Federal Bureau of Prisons. So it can affect me as far as pay, but as far as policy, as far as patient policy, it doesn't affect me, because I see who I want to see, and I see everybody that I have to see.
Okay, and it doesn't affect like what treatment you would be giving your patients or anything like that?
But it does. Remember, I said the whole thing about formulary medication. So, so it affects it in that, okay, if I want to give somebody Latuda, okay, Latuda is a good medication. Latuda is a great antipsychotic bipolar med. We don't just have that in the prison system right now. We don't have it. It's a special request that I have to make if I believe that inmate needs it. But if we don't have the budget for it, they'll be less inclined to approve that medication for me to give. So I guess that in a way it does, but I think there's so many other things that I use that I don't let it bother. I don't let it bother me, because I use other medications quite frequently, but that could be one way it could. If the medication is, like I said, the medication is not on formulary and they really want it, I have to make a special request that has to go up to DC central office and they have to approve it.
Thank you.
You're welcome, dear.
Excellent question. So before we get to Luna's question, Luna, you're up next. Dr. Okafor, you mentioned COVID, and I wanted to take a moment to focus on health disparities and real-time issues. So with COVID-19 disproportionately impacting those in prison, as we all know, right? And people of color, and even probably more so men of color in prison. How have you needed to adjust your work?
Great question. So essentially, prisons and jails have been, were hit pretty hard by COVID, right? So for me, I no longer had patients coming into me, because one thing that changed in the BOP was they started having the movement was stopped. Free movement that was going on was essentially stopped. So clinicians like me had to gear up and see patients. So I had to go up to the unit, take patients from their cell and bring them to a special office within each unit and see them gowned up. So for some time, when it was really bad, I think it was March, April, May, and June, I had to gown up to see my patients, which I never did. Obviously, I never did before. They no longer had that movement that they did prior, where they could just come downstairs, say, hey, I'm going to go see Dr. Okafor, and the correctional officer of that floor would just point them to where I'm at. I had to go up and see them in the unit. I think that the BOP has done and I know it's going to sound like what's the terminology? A PQ, polite answer to say, but I think they've done a great job as far as delegating, helping to stop the spread, because we no longer, the movement is not as much as it used to be. And you have the clinicians like me go up to see the patients in their actual cell or in their unit, and we take them to a special area of their unit. That's what I had to do, and that's what I've gotten accustomed to. Only as the COVID numbers in New York have become more stable, New York, Jersey, and Connecticut, have I been able to get them to come see me, but I still have to get special requests for them to come see me. That's been the only real change. As far as their treatment, nothing has changed, obviously, but seeing them has changed. I mean, their movement around the prison has been decreased for the right reasons, especially since lawyers can't come anymore. They have to do video conferences, kind of like why Zoom, including this, this wonderful Q&A is happening, has definitely increased services while trying not to keep inmates from having the rights that they have as far as legal representation and all that other stuff.
Thank you. Thank you for that. All right, we have a great question. And Luna, this was also on my list of questions, so I'm loving the questions. If you can please introduce yourself and ask your question.
Yes, how are you, everybody? My name is Luna Maria. I am originally from the Dominican Republic, but I now live in New York City for 12 years. And like Danya, I'm actually starting the post-bac program now.
Wonderful.
So
Welcome.
many years, thank you. So many years ahead before I actually decide where I want to go to in terms of a specialty. But I do know that I want to go into psychiatry or internal medicine, but let's see. So my question was, when I think about psychiatry myself, I usually wonder, how do I set boundaries with patients as a physician? Because, for example, I usually get attached to people, especially if there is an ongoing conversation. And so how do you make sure that the conversations and the patient's stories stay in the work environment and that you don't bring them home? Because from what I have heard, psychiatrists and even therapists themselves usually have therapists so that they can deal with the trauma that their patients have gone through. So I just want to know how your experience has been so far, and thank you.
That's a great question. Absolutely wonderful question, Luna. Okay, I'll just say on my end, since residency, everybody has always told me I separate work easily from my social life. I can't tell you how to do that, like how you can do it, but I can say there's nothing wrong with sharing your experiences with your patients. I think patients look at physicians and all these clinicians that take care of them as they think that we're so above them. And I try to make sure I level the playing field by sharing them with my experiences. Because I'm dealing with inmates, I don't get into details about where I lived and stuff like that, but I do my best to share my experiences. There's nothing wrong with that, as long as you know there's boundaries of what you need to share or where you're not overstepping the boundaries. And you'll learn that eventually, like you'll learn that through experience. You'll learn that through experiences. When you get into medical school and residency, you'll learn the boundaries that you need to implement from the beginning. But do I think there's not anything wrong with sharing information of your life? No, because patients need to understand that you're giving them great care, but you're a human being just like them, and you've experienced any kind of emotion they've experienced. So I try my best to share that with them. I don't try and hide that, but I do try to, just maintain balance, and you're going to discover that on your own, how you want to maintain balance, or what's too much to share. But that's going to be up to you, and that's going to be up to your level of comfort with your patients. I've always been told that I separate the two very, very easily, because I have my professional life where I'm going to take care of my patients, and it's my blessing that you're letting me be part of your care so you can be better as far as your functional, et cetera, et cetera. But then there's my life too that I gotta live, and I feel like I deserve to live my social life. So I separate the two. I've always been able to separate the two. But you're gonna find your own balance of what you can share and what not to share. But that's gonna be your own. That's gonna be your own journey. But know it's important. Know it's important. You don't want to take work home. Know it's very important. But over the years you'll learn how to not take work home and what you can leave in the office.
Great. Thank you for sharing. One of my mentors has always said, professional is personal. So, and I know a lot of you guys, you want to do amazing work in medicine and helping those in need. And as Dr. Okafor said, is just finding this right balance of giving it everything you've got, and at the same time making sure you're guarding yourselves, taking care of yourself.
And nobody can tell you what's that perfect balance. You're gonna have to discover that for yourself. It's for yourself. That's why I never say, cut it off here. No, you'll know with what you can share and what you can't share eventually through experience.
Great, thank you. All right, we are getting, there's great questions, and I'm also being mindful of the time. So I'm gonna move on to the next question. And I think Christiana, he kind of answered some of this, but please go ahead and introduce yourself and ask your question.
Hello, my name is Christiana. I am a current postbac student. And my question is, how do you ensure that your biases, if you have any, or past experiences do not prevent you from humanizing your patients, especially when you first started out as a psychiatrist?
Right. So the question is, how do I don't pass on my biases to my patients?
Yes.
Is that what you said, Christian? I just don't experience. Once again, I just don't I've been training. I've gone through training. So I've gone through people critiquing my interviewing skills, etc. So when you go through training, you see enough patients and you have the right mentorship, you'll see the right person or leader will tell you where you went too far, where you didn't go too far. So I would say it's just experience. And it's just experience. I don't push my bias. I don't give political and religious opinions. I give medically evidence-based opinions about, not even opinions, factual stuff about medications, therapy that I've trained in. So the stuff I'm giving is not really subjective. I think it's very objective. I try not to give biased or subjective opinions and that goes through just constantly practicing interviewing through training. And that's the best time you'll get a lot of your nicks and cracks out the way by somebody critiquing your training and how you respond to patients. And that's where I got all my, residency. Residency is great. It's the best time to learn with no fail, and people just want to see you do better, just like they did, your seniors above you. So residency.
All right, thank you. So Dr. Okafor, we've got 2 more questions from students, and then we can wrap things up. Hopefully you're okay with the time here.
We're good. We're fine.
Great. You're in cruise mode, vacation mode.
Thanks, Montel. Thank you.
So our next question is going to come from student Neka. Hello, Neka. If you can introduce yourself to everybody and ask your question, please.
Hello, everyone. I'm good. My name is Neka Amumer. I'm also from the Bronx, Kingsbridge. And I did the Medical Scholars Program at Upstate Medical University, and now I'm a first year.
Congrats.
Thank you. All right, so my question, it's a little long and you kind of answered a little bit of it, but I wanted to know, in the case that you may have people that you know or people you might have grown up with that may have been sentenced to prison time and they're working to not go back, and especially like you don't even have to do something for you to end up in the system. Have you ever like lent your services to those people and maybe like talk to them the way you talk to the people you actually work with?
I mean, okay, there's a few questions in there. So which one do you want me to focus on?
I would like for you to focus on if you lend your services to people that you know who have been in the system.
Okay,
like,
so
you spend time with them.
Okay, I don't know anybody. Out of 7 years I've been in that prison in New York, I've never met anybody, and I grew up in New York, so it's been very surprising. I've never met anybody I've ever known, right? But
Okay.
But as a psychiatrist, and I do talks like about once every couple of months. I talk to an inmate unit. I talk to them about my background, what I did, what I'm doing, what programs are available. I do that for them. So I do that about once every couple of months. I let them know what are kind of the residential entry programs that are available for them when they leave prisons. But it's all general stuff. It's nothing too in depth. I kind of leave it to the unit managers, the case managers. Those are the people that are gonna link up the prisoners to the outpatient programs. Yeah, that's the most I could say.
Okay, cool. Thank you.
You're welcome, Neka.
Great questions. All right, so we've got one more from a student, and let me know if I'm pronouncing this correctly. Gerlin? Geraldine, are you still here?
Yes, I am.
There she is. Okay, hello.
Hi, my name is Geraldine Garrow, and I'm from the Bronx. I am part of the current
Bronx is representing pretty strong today. I'm just saying. I'm just saying. Jeez. I love it. I haven't been there in a couple of years, like a year or two. So it's just crazy. I live right here in Jersey City, so it's always weird. I haven't been there in forever. So wow. Making me smile, all these Bronx people, like, wow.
Yeah, but I'm excited. It's exciting. So my question for you, which is something that I've always been noticing, especially through my shadowing and experiences, is like the teamwork between doctors, but there's also the subtle like criticism of some treatments, but they always try to not step on each other's shoes regardless of their personal opinions as providers. So you mentioned how another doctor takes over and now you're on vacation, so the doctor that takes over for you and your patients, like, will they stick to your treatment plan? If you came back, will you see something different? Do you meet? Like, how does that look like?
That's a great question. No, extremely great question. So because psychiatry is one of those specialties that we have so many different medications. People have their favorites. People have their favorites and what they use and what they don't use. I have really good relationships with my colleagues. So although I'm the only psychiatrist at my prison, when I go on vacation, somebody from around the nation, because we have something called telepsychiatry, takes over my patient load while I'm not at work, right? I know all the telepsychiatrists. We've all worked together at least. I mean, I'm the youngest, but we've all worked together, I would say, for the last 3-4 years. So most of us will continue the treatment plan, maybe add a dosage and don't completely change it. But because I know I know the telepsychiatrists that I work with, I know they're competent. I always think that they can change whatever they want to change, because at the end of the day, it's not an ego-driven thing. My only concern is the patient is doing well up to the next day, whether it's they're psychotic, whether they're too anxious. As long as it's in good intent, which it always is 100% of the time, for the patient to do better, I don't mind them stepping over me and adding something or changing something. And then when I come back, I review what they did. And I will tell you 98% of the time, I've totally agreed with what they did. So because I have that relationship with them, I'm always about them doing what's best for the patient. I don't have that ego to say, oh, I did this. Maybe the first time I thought it was the best move, but you know what? You took culture and you did something better than I probably would have done. So thank you for treating this patient thank you for adding to this patient's care.
Okay, thank you.
But again, I don't work at a private clinic. I work at a prison where I do my thing all the time. So I don't have to deal with it on an everyday basis. So you're coming from somebody who's very biased in my environment. So let's just, everything I'm saying with a caveat that I work by myself 90% of the year, 95% of the year. So.
All right. I mean, this has been an amazing conversation. I want to thank Dr. Okafor for joining us. It is truly a pleasure. As you've said before, you just, it's real talk. And I think the students really got that today. We don't often have that opportunity. So thank you for sharing your professional, your personal with us. Want to thank this. Yes.
My blessing.
And thank you to the students, our new post-bac students, our medical students. I don't know if there's so many unique names here. If we have maybe residents or practicing physicians on board, I don't know, but I'm super happy that everybody made it. Let's continue this. This is our first one. We're planning on having these monthly. As Jenny said in the group chat, don't forget if you have nominations of someone, a mentor, a role model you think would be great to have on this webinar series, just email us and we'll get in touch and make it happen. So, and I think that's it. Thank you, everybody. And,
thank you, everybody. Thank you for the questions. Very challenging questions, but those are that's how we spread knowledge to one another. So thank you, you guys, doctors, future doctors. Well, all future doctors, but I'll just call you doctor now because it's gonna happen.
That's right. All right. Thank you, everybody. Take care.
Take care, guys. Blessings.
Till next time. Enjoy your vacation, Dr. Okafor.
I will, man. Thank you. Take care, guys. Mm-hmm.